As you know, the Chair of Finance, Mr. Steve Montgomery, would normally be sitting in this chair. He is not here today and asked me to stand in for him, so I will try to get through this.
We're gonna get you a countdown.
Oh, we're gonna do the
Slide for the gavel.
Okay, just
5, 4.
there you go. There.
All right, now I'm official. Thank you all very much for being here this morning. As I mentioned, that normally Mr. Steve Montgomery would be chairing this committee. He's out of town and asked me to sit in for him, so I will try to get through this today. I have been advised we will call this meeting together to start at 10:10. I will also mention that there are no citizens here today to address this board, which would take us all the way down to item number 3 on our agenda, which is the August 24th amendments, minutes, which have been provided. If there's any discussion, we will entertain that. If not, I entertain a motion.
Second.
I have a motion by Dr. Weber and a second by Reverend Emerson. All those in favor say aye.
Aye.
And then I think at this particular point in time, as you notice, item number 4 is the CFO report. Obviously, we're nearing the end of our year financially, so there's a lot to do. You'll notice on the agenda, there's about 25 items, plus we have an item for close also. So Sharon, we will turn this over to you to start our meeting. Good morning.
Good morning. Thank you. I just have 2 items as updates on my CFO report. As many of you are aware, the Commissioners Court did approve our 18 budget at the September 12th meeting. So it is finalized and we will move forward with that budget. We also, just as a reminder, our year end is September 30th, so we just have a few days left in the 17 fiscal year. So we will be very busy taking inventories over the weekend, especially in the surgery areas. I will be covering just in a few minutes August, which will be our 11 months. So we'll just have one more month of performance for 17. Yeah, I was down, and in our materials area, we were down celebrating an employee that was retiring with 40 years of service yesterday. And as Robert and I were walking around talking to some of the warehouse staff, they were keenly aware that Saturday we were going to be counting massive warehouse inventory. So depends on where you work, how significant September 30th is. But anyway. So if y'all don't have any questions, I'll go ahead and move into the August performance. We actually had a very strong month, both in inpatient and outpatient volume. Admissions were up about 7.6%. We had 2,424 admissions. It was not our highest month, but it was one of our highest months for this fiscal year so far. Our patient days followed at about 5% over budget. Our case mix index was just slightly under at about 0.5%. We've always had the indicators with the green or red boxes, but I've added a new yellow box because if it's just slightly under budget, I did not want to show that as always being red. So if it is just under by 3%, I'm going to start to show those as yellow. It's just slightly under budget. And then anything greater than 3% under, you'll see as a red box. If it is over budget or favorable, then you will continue to see the green box. So just slightly unfavorable will be the yellow box. So that's new for this month. And length of stay is favorable. We had our length of stay come in at 4.88 days compared to a budget of 5.1. So we were getting our patients discharged timely. So for outpatient, we had an incredibly busy month compared to our budget as well as actual. So a lot of times when I report on our volumes, sometimes we budget a really high month and we're just under budget. But this month, when you look at our trend, we were very, very busy on both ways you look at it. ED was the highest in the 3-year trend that we have ever seen. So when you look at this, we saw 11,607 patients this month for August. That is an average of 374 patients a day for the 31 days in August. I did not go back and look at the daily to see what the highest daily total was, but that is a lot of patients in a 24-hour period, knowing that they did not come in just evenly throughout the day. So, and then if you drop down to the bottom left graph in urgent care, moving over across the street, offloading the less intensive patients, urgent care saw an additional 168 patients on average during that same time period. They saw 5,195 patients during the month of August. So, you know, if you look at that side of the equation, that is a lot of unscheduled visits at any given time. Our total clinic visits at the top right, those are our satellite clinics throughout the community for the most part, primary care, specialty care. We saw 64,600 clinic visits. Again, that is the highest in the 3-year trend, and about 1.5% ahead of budget. So extremely busy in the outpatient area. A lot of that is attributed to some of the changes that we've been making in those clinics, as well as getting staffed in the primary care areas. So all of those factors contributed. Yes, I'm sorry.
Before you go further, I just want to ask, how many urgent care facilities do we have? Just the one?
Yeah, the main urgent care, the urgent care facility is located on the first floor of this building. Now, a lot of our community clinics do have after-hour care and same-day appointments. So you can obtain, you know, a primary care type visit. It's just not designated as an official urgent care or licensed as an urgent care clinic.
Because that question was asked of me the other day. They were on their way to emergency, and I said, go to urgent care and not emergency. And then I got to thinking, I wonder how many individuals know the difference between urgent care and ER visit. When I saw that, when she talked about those numbers, that's what made me raise that question.
We have developed a very strong synergy that didn't always used to exist between emergency and urgent care.
Right.
And we have governance and authority on both sides of that from the same group. So it's really helpful now that we have that. And so even if people do get confused, and we still have people that show up thinking that the ER is still in this building. I think that's really declined a lot because we've had wayfaring and getting people in the right direction. But I think we've done a pretty good job of creating a real link between urgent and emergency care and the proper way of getting people funneled in the right way.
Can a sheet be developed or something that where a person could look at to determine, do I go to urgent care, do I go to ER, or is that too fine?
I don't know that you could actually write it down on a piece of paper because I think a lot of it's going to be and I'm a layman speaking, but I think it's going to be the judgment call of both urgent care clinicians and the ED clinicians. Dan, Dan Casey or Dan Ziegler, wouldn't you all agree?
Yeah, there's a triage nurse that kind of helps decide that. You know,
Right.
show up,
Yeah. Okay.
Sorry.
Oh, that's fine. It's
No,
a good
that's
question. I would add, though, for established primary care visits, we even would encourage patients to contact their primary care physicians to see if they can get a same-day appointment. We would want them to continue the care in the clinic setting even before they access urgent care. So. Our other key statistics and observation days, we were under about 3.5% for observation days, even though we continue to trend of almost 1,900 days. Our inpatient surgeries were down by about 4% from budget, and our outpatient surgeries were down by 1.7%. And at the top right, invasive lab cases were 2.4% ahead of budget, almost 640 cases this month in invasive labs. In psychiatric service line, our patient days were slightly under by about 1 percentage point, about even where we have been for the last few months. Our clinic visits are very strong, 5% over budget. We saw 3,160 patients in our outpatient clinic settings. The Psych ED continues to be on trend. We saw about 1,620 patients in the psych emergency setting. And our partial hospitalization days are slightly rising, 610 visits there for August. Oops. Our FTEs per adjusted patient day continue to be favorable. What we look at is the total paid FTEs per adjusted patient day. So I'm looking at this 5.93 compared to our budgeted target of 5.96. So that is a good favorable position to be in. This is the total 11 months. So this kind of tells me, based on our volume, not based on our fixed budget, but based on the volume of patients that have come through our door, how have all of our departments adjusted their staffing, all in total paid. And again, we are favorable there. Days cash on hand. Again, we got our big cash payment from our ad valorem taxes kind of in this time frame, and it will continue to decline as we spend down operating expenses. At the end of August, we were at 249 days cash on hand, and our net accounts receivable days has leveled off at about 53 days. In our payer mix, we continue to be around 40% unfunded, which means 60% of our patients do have a funding source, as you can see. A lot of that is Medicare and Medicaid. We do have about 14% commercial. And our JPS connection enrollment is leveling off at about around 40,000 enrollees for fiscal year 17. So for the month of August, we had a positive bottom line and favorable to budget from an operating margin standpoint this month, about $1.3 million from operations compared to a $900,000 budget. We beat our budget by about $400,000 for the month. Two main reasons for this on the top side were in net patient service revenue. We had $3.5 million worth of favorable outcomes up in volumes and payer mix. For the last few months, we've been talking about just a slight shift each month in that payer mix can cause $1 million worth of collection expectation difference. And in June and July, we had an unfavorable shift. And it's kind of who walks through the door, who gets admitted, what types of services that they require. In August, we had a little bit more commercial payer mix than we have had in the few months and compared to budget. That helped us. And we've also had a little higher Medicaid eligibility come through in August as well. So those three factors helped us in that top line. And as a reminder, we're also accruing a little bit less in that uncompensated care, our waiver revenue, that $833,000. So there are no surprises at year end. And then in the other operating revenue, most of that is our pharmaceutical assistance program, our PAP, our drug. It's not a grant, but we record it up in the grant section and other operating revenue. There's a big offsetting expense down here, so there's not really any net income impact of those programs for a lot of our patients that qualify for that. Also, in the other operating revenue section, we were able to recognize a lot of additional unbudgeted grant revenue that we're working on. As I mentioned, we had a really busy month, both on the inpatient and the outpatient side. So it did cause our salaries to be over by about $840,000. But if you looked at that FTE per APD on the month, we performed favorably on the month as well. It was a 5.81 compared to a 5.99 budget for the month. So we were reacting to volumes there. Our benefits number is favorable by about $350. And since we talked about the pension funding last month, I thought I would point out that we are going to see a favorable pickup in our pension expense both in August and September, because based on that actuarial report that we received, our pension benefits actually performed better in the market this year than they historically have. You know, we look at a 3 to 5 year average, and we're not having to fund as much expense because it earned more interest income. So we had a little bit of a pickup in August, and we're going to have a little bit of a pickup in September because we're not having to put as much money in that because those interest earnings have offset. So anyway, you'll see, hopefully you'll see a little credit there in benefits next month. We talked about, when I talked about PAP drugs, that was actually down on that next line item on supplies. Trying to get too fancy here. So we've talked about the supplies. The purchase service, we are over about $2.2 million in purchase services. Our trend for outside medical services continues to deal with the overflow in our psychiatric ED to from our outside medical services. And that accounts for about not quite half of that purchase service overage. The other half of that purchase service is payments that relate to physician services that are dealing with all of the patient volumes that are coming through the hospital for that 40% of unfunded patients. You know, that's part of the connection program, and it's also how we get physician coverage for the self-pay part of the inpatient as well as the outpatient follow-up for that care. So again, that relates to a large part of the patient volumes. But overall, the bottom line there was $1.3 million from operations. We did generate about $600,000 from investment income and non-operating revenue for a bottom line of $1.9 million. Year to date, we have a $3.8 million loss from operations 11 months in. A big part of the gap was due to the loss of the UC funds. That was unexpected. We've talked a lot about that. Looking at the bottom line net income, we are at a positive $3.3 million. Are there any questions on the hospital?
Just have a quick, the chart that we have, the payer mix. Is
Yes.
there any way we can look at in the chart so that we can see the volume by payer, the gross charge and the net collection? That way give us a better way of measuring how we're doing. Because from time to time, I keep on forgetting, are we counting patient? Are we counting revenue? Are we counting actual charges? Or are we counting net revenue on this one?
So the payer mix, I'm really trying to show you the heads that walk through the door when you look at the payer mix slide. So this payer mix slide is the gross charge.
Gross charge.
And if I show it to you based on net revenue, there's going to be zero self-pay because you don't collect anything from a self-pay patient. So if I showed you this payer mix slide on what we collect, it's going to look like someone might look at this and it's going to show a huge portion of commercial, a huge portion of Medicare and Medicaid. And you're going to kind of lose the fact that JPS actually serves a large part of commercial. So if you look at this, and the reason that I typically show payer mix based on gross charge is because everybody remains equally weighted regardless of how much you collect from a patient on a net basis. But you know, you can slice and dice it however you would like to see the payer mix. But this kind of shows everybody equally weighted as they come through the door.
Maybe if we can see the volume, the number of patient count coming in, and the charges, so that we can see, are we dropping, is up?
The difficulty about patient count, and I am willing to try to get you however you want to see it. The difficulty about patient count is it's really hard. Inpatient counts are easy because a head in a bed is pretty much the same. But when you get into an outpatient setting, it's difficult to equally weight a radiology, an MRI count to a lab visit or a pharmacy dose. So when you start to try to globally count total outpatient and combine that with total inpatient, you start to not be able to combine overall, and you almost have to convert it over to revenue dollars. So I'm kind of back to this pie chart.
Well, I guess the question I would have would, I mean,
is it weighted from what's costing us? I mean, for all I know, the commercial patients, we're collecting maybe $1 million, but if you look at the self-pays, their care is much more complicated, and it's costing us $5 million a month.
So when, there's not, that's probably not a pie chart.
Okay.
When we get our cost accounting information available to us, probably in the next 9 to 12 months, we'll be able to start to bring you and educate you based on some of the information that you're probably curious about, and service lines and profitability of certain payers. But right now, that would be more of a guesstimate. We don't have those databases that are sliced and diced that way. But it is coming, and we are kind of, I would say 35% through that process of building that system.
I think part of the thing that I'm trying to get an understanding a little bit for more appreciation for how people operate
Yes.
is more like, because we really shifting away from fee-for-service, kind of moving toward more of a managed lives.
Mm-hmm.
I mean, the JPS connection is managing lives.
Yes.
And how are we doing, if we're putting 8% of our business and 13% of our Medicaid business into the managed care / Medicare Advantage type thing, how are we doing? What is the bonus potential may look like? Are we hitting our HIDIS measure? Are we hitting our G-Pro and all that stuff? Because it start out with reporting first, and then we all know that pay for reporting, and then it's going to shift over to pay for quality and all that stuff, to see where are the dollar investment that we need to put in, and when are we getting traction on that, so that it can help with the contracting and all that stuff down the road. It's just trying to measure to see how we're shifting to the quality side, because we are going to be putting a lot of some of our risk on the quality, on the patient, on the wellness and all that stuff, and how we measure against those that we may put at risk in the beginning, smaller, and then as we get more and better at it, we put more at risk on that side. For HIDIS measure, for all the quality measure and all that stuff. And then we have to shift for utilization, right? To look at how we're doing. Are we utilization? Is our referring pattern correctly? Are we, then kind of follow down the road to see how the patient's doing. Because it's just a measurement of, I'll give you an example. If we ever moved, we're taking care of our patient, how we doing from the surgery side, how we doing from the rehab side, and then how we spending on the pharmacy side. And over time, we may have to look at to see, are they drug dependent afterward? What can we do? Because that's intertwined with our other program.
You can ultimately do, Sharon, a cost allocation. What you're doing now is you're counting, these are human beings coming in, and you're allocating them to those individual payer mixes. Where DT's going is more detail, ultimately, cost accounting, whatever, is how much are we attributing financially per those classifications, and how we can better manage that as we move toward more quality.
Right.
I think, yes, I mean, you ultimately be able to do that, but that's not what this slide currently depicts. So I think it's something we could look at as we go forward, DT. I think
It's just a shifting.
I think it's a good point to look at, but that's not what this is. This is not based upon the cost per person walking in the door. This is the means by which we expect payment at the current time. Did I get that right?
Right. Well, this is actually just the charge accumulated
Accumulated
by every person that walks through the door. So it's not even expected payment or, there's no assumption at all. It's
just a
just
gross.
everybody equally weighted.
Okay.
What do our patients look like? And what's the volume of those patients?
Right.
Equally weighted, removing expectation of payment, removing cost, kind of who's the face of the patient if we were to divide them up by payer mix.
Okay, good. Okay, anything? Go ahead, Jen.
And DT, we can have a conversation after the meeting, and maybe I can give you some information that would be a little bit more helpful to you. So if there's no other questions on the medical center, I'll go ahead and move into a claim. On the a claim side, our build encounters this month were close to budget. We were about 1.5% lower than our budgeted encounters for this month. Again, the graph on the top right shows the mix of the physician specialties that are employed, and although it's labeled physician, this actually includes both, it's all providers, and we'll change that graphic next month. This also includes our nurse practitioners as well. The claims payer mix is calculated the same. This is based on charges. They do have a heavier weight because of the women's health component in the Medicaid area than the medical center does itself. So for August, a claim had a loss of $340,000 compared to a budgeted loss of $662,000. There's a main reason for the favorable outcome for a claim this month. Up in net patient revenue, we did have some billings that related to a prior month that we were able to go ahead and catch up for on that. So that was the main reason for the favorable month. We also, in other operating revenue, if you recall, there have been a couple of large contracts that were assigned from the medical center that are now flowing through a claim, both on the other operating revenue side as well as the purchase service side. That is for neurosurgery as well as surgical services. So we have income from the medical center, and then we have expenses getting paid out to the third-party physician group. It's a zero impact for a claim, but we don't have any budget. So on both of those line items, there's about $1 million worth of variance. Also hitting in other operating revenue are some UNT payments for both medical education and academics. That's kind of a year-to-date catch-up there, as those contracts have gotten signed and calculated. So there was some catch-up there. Again, in salaries, we have here, we have a little bit of an overage for some call pay. We reconcile call pay periodically on a quarter basis, as well as the implementation of the comp plan, if you recall. So there were 2 items that hit this month. And then again, overall, it was a favorable month compared to budget as planned. Year to date, we're at a $14 million loss for a claim. And there will be a few year-end entries as we start to plan for the year-end. I'll be bringing probably a few extra slides back to you guys next month to kind of show you a normal month in for both the medical center and a claim, and then the few year-end entries in preparation for the year-end audit. That might be some special entries.
Before you move off for that on the purchase service,
Yes.
I think this is about the second or third time we have been catching up on some education payment. I don't know if it's UNT, wherever, but this is, I've You've given us that a couple of times. So have we finally caught up now?
So the purchase service is actually, the UNT is actually income for them. There's no expense associated. So the UNT, there's two components to this. There's about $1 million for the UNT for income coming in. And that's just income. That's for UME as well as academic funding.
Okay.
And that's to cover some of these salaries that we're paying for employed physicians. There's another component to this operating revenue. There's another $1 million for 2 contracts that were assigned. And that has been a couple of months that we're talking about.
Okay.
There's $1 million worth of income here that's coming from the medical center, and then there's $1 million worth of expense that is getting paid to a third-party physician group for coverage because of that assignment. And now, the assignment activity nets out to 0 for a claim. But the UNT is simply income to cover the salary cost for the physicians that are employed currently.
Okay.
Does that make sense? The UNT,
Yeah.
the UNT activity is not an expense. If I said that wrong, I apologize.
Okay.
So Sharon, I have a question. I'm probably the only one in the whole room that doesn't know the answer to it, but I'm asking you. When we're coming up on a new budget year, and we have budgetary allocations that we had really no ability to predict. Dish waiver, for example, or a claim losses, for example. What, and maybe this is because of you, Charlie, what is our policy relative to amending the budget based on unforeseen financial occurrences relative to metric achievement when it comes to looking at the system's administrative staff's goals on income? Because if when we see these huge changes in the budget, both of these were unforeseen, both of these were not something that we could have predicted this time last year. And we probably can't predict it actually this time next year, honestly. But when we talk about our metrics relative to how we evaluate, for example, our senior staff, meeting financial metrics is one of those components. So my question is, and Dorothy and I talked a little bit about this last night, my question is what is our policy relative to amending the budget to adjust for unforeseen circumstances that we really can't fairly hold staff accountable for relative to metric achievement when it comes to performance evaluations?
And you probably asked that question more professionally than I'm going to give you an answer, but I think what you just said is something we're going to discuss. As you know, we have HR coming up right after this meeting, and I think your points are well made. We've carried the $10 million loss all year. You and I both know in normal businesses, we had no control over that. When we're sitting here talking about having that loss, even I can add 10 million back and we don't look so different than what we were. As you know, this year we got hit with things right at the time this was approved by the commissioners. And the day before we got hit with an IGT situation we had no control over for $14.9 million. I don't know what the official policy is, Trent. I would hope this board working together would look at that when we do those evaluations, like the business world does it when things unforeseen happen. I feel quite sure Houston, Texas, the business community is dealing with some things that's happened that they didn't have any control of, that hopefully their CEOs and their senior staffs, that doesn't penalize them. So, and I hate to use an example like that, but sometimes things happen. Our funding model here depends on a lot of things that we have no control over. So back to your question, I think, do we hold them accountable just to that? Or do we have the ability as a board to look at that and say these were things that those management of the institution had no control over? How do you govern that better, I guess is my question.
There's discretionary budgetary decisions and non-discretionary budgetary decisions. And there are discretionary revenue categories and there are non-discretionary revenue categories. And so, you know, within the context of Dorothy's committee, we really, our scope is to look at those metrics, do you achieve them or do you not, period. Within the scope of this committee, we've got to be able to take a hard look at the numbers, to see whether or not those numbers merit budget amendment on non-discretionary alterations in order for Dorothy's committee to have a fair shake at doing what we're supposed to do within the context of the HR evaluations. And I don't know if we've ever dealt with it, but I know the scope of these non-discretionary changes is such that it's going to have a sweeping effect. And I think it would be worthwhile for us to at least consider, and maybe it's not a policy, maybe it's just a procedural process that says, let's consider these things that are non-discretionary changes. And we may need to argue about whether or not they're non-discretionary.
Agreed.
I'm fine with that. But I'm not fine with when the state says you're gonna get X and we budgeted Y, holding people accountable for something they had absolutely no ability to control whatsoever.
Right.
And among our administrative staff evaluations, the achievement of that financial metric is a weighted element. It's important. So I would just, you know, in the context of both of these committees today, and thinking a lot about this, as Dorothy and I talked about last night, I think we need a path to consider that relative to those two committees' scope.
Okay. I think it's a good point, and I don't disagree. I think that's something we can discuss further in HR because it comes up. I think the reverse is also true. We talk about the issues up there that we cannot possibly hold someone accountable for because they were totally outside the realm of any decisions they made. I would also say, looking at financial statements, is there additional revenue that came from sources that we didn't anticipate within the budget? Also, when you start, that's why I think we need to truly look at it. And I agree with you, we ought to truly look at that. I think this board has the ability, when we're doing the evaluations, to consider both those things. Back to amending the budget, I think that's something we can certainly discuss. I mean, I think you've been carrying $10 million. I mean, you sat here each month this year and told us that $833,000 is something we had no control over. There's so many other numbers up there that we didn't have control over. And I think Dorothy's questions even about the acclaim budget, a lot of the stuff in this year kind of came up that we knew it was a year getting through and getting a claim set up. And some of those things came through that were not assumptions and/or were. So I think the timing is perfect, Trent. And I think the point's well made because they do fall off each other. If you don't have this set right, it's hard to hold someone accountable when they have no control over
We
it.
gotta be fair.
Agree.
You know, I'm guessing because it's raining outside and you had to drive on 121, you had plenty of think time on your way. Good.
This is one of those topics.
That's good. I think,
Watching the red tail lights.
good. I think the point's well made, something we will follow back up.
So, yeah, right, HR topic, because as you look at amending the budget, you also have to go back and amend the staff.
We do.
Yeah.
The metrics.
Right,
Right?
right,
Yeah.
right.
Well, I know for HR committee, that's a major discussion we will have. And I think for this committee, for us to start looking at what, and identify what we will make those exceptions for. Because I don't know anybody's budget that you set, that everything is gonna be exactly as
Right.
you want it. So I'm not willing to say that can't have some things, but we can look at some of those unusual things. Because we are a hospital that have taxes coming in, they might change. So as a budget preparer, we need to be anticipating that. So there are some things I'm willing for us to look at, and we should identify those, okay?
Good. And I will meet with Chairman Montgomery. Trent will follow up to make sure, because there's two questions here. One is the assessment of our staff. how they do compared to budget, that's more of an HR issue. I think your question, Trent, also has an additional piece in it, that throughout the year, if some unforeseen things happen, we realize next January, our GT's gonna be off again because some governmental adjustment or whatever, do we have the right to come in and say, let's just do a mid-year correction to this budget as opposed to carrying all this, that was way back last year and we're still carrying the problem. Maybe we come in and we can address that. And I'll get with Steve on that. We'll get back to the board on that one. No, I think the point's well made. Sharon?
Unless there's any questions regarding a claim, that was the only comments that I had for a claim today.
Any other discussions for Sharon on item 5A, which is the budget? If there's not, I would entertain a motion for approval of the finances as presented. Have a motion by DT, second by Dorothy. All those in favor say aye.
Aye.
Thank you so very much. We would then move to item number 5B. Sharon, while you're there.
Spivey Health Policy, if you guys recall, a few months back, y'all approved the contract for Spivey. He provides oversight for all things complex and governmental, like our UC and our DISH advisement. That contract was for fiscal year 17 for 1 year. This contract that we are asking for approval today is for a 3-year contract that would begin 10/1 and move forward. So it is the same services, just a 3-year contract, trying to be a little bit more proactive.
I would add to Sharon's comments real quick, just so you know about this. This is, Mike Spivey's had a relationship with this organization, and Mike serves as a go-to person when we get those changes y'all just discussed a while ago. When you get a $14 million hit that was unsuspected, Mike's very helpful to us in that regard, and it's hard to predict when we need him and when we don't, but we find here most recently we need him a whole lot more than we used to.
There's rarely a month that Robert and I are not seeking advisement from the firm.
Is this a fixed fee or is it a retainer or I can't tell.
It is a fixed
Fixed
fee.
fee. And I just, as counsel, you may have seen it also on the termination clause, has the same termination clause as any other. It's 30-day also in this contract. So, any other discussion? If not, I'd entertain a motion. Have a motion by DT, second by Dorothy. All those in favor say aye.
Aye.
Thank you so very much. We will then go to, thank you, Sharon. Sharon, thank you very much. I think probably this first time finance has met after you went through a lot of presentations with the commissioners and follow-up and changes to the budget and various other things. And I think on behalf of this committee and the board, we say thank you very much for all you did, you and staff, during that process. So thank you for everything.
Thank you.
Okay. All right. All right, Bill, item number C.
Good morning.
Good morning, Bill.
Yes, item number C. This is staff's recommendation to approve and would like your consideration in regard to a 5-year agreement for our pharmaceutical wholesaler. It is a lot of money, and we have put together an RFP of which Amerisource, Bergen, Cardinal, and Morrison-Dixon responded. Morrison-Dixon is our current drug wholesaler, have been for the last 5 years. This was the most cost-effective proposal that we received from the three, and it resulted in a $450,000 annual savings over the 5 years of this agreement. But in spite of that, it's still a very, very large contract.
Bill, if I could make a correction, I think you're actually on item D. The ProPath is item C.
I thought that was enclosed. I am sorry.
Does it need to be in? No, it does not. It is not to be enclosed.
It will not be enclosed.
Yeah.
All right. Well, let me back up then.
And yes, D is,
Save some time on the next item.
that's right. And yes, D is expensive, Bill.
Mistake.
Now, back to C.
Might make it a whole lot
Oh, yeah, C may sound better after talking about, yeah, thanks, Bill.
Okay, the ProPath agreement is a request for services to be outsourced to ProPath for anatomic pathology. And as we have talked many times before, in this meeting, the board meeting, and the quality meeting, we have some endeavors around our operations in the lab that we're continuing to find opportunities. And this is one of those sections that we feel there are opportunities that the outsourcing perspective of anatomic pathology would provide us. We're making a lot of progress in the lab, and we need to update you more formally at a later time, but we had a CAP visit last Friday, and they brought 12 people. They usually bring 7 or 8. They brought 12. They spent the day here, and it was a good summation. The chief medical director who was there was very complimentary of all the work that had been done, all the progress that we have made, and there were significantly fewer Phase 2 reports than we had 2 years ago. So I'm happy to report we're making a lot of progress in the lab, but AP is one of those areas that we have attempted to find supervisory staff, management staff for a long time, cannot. Don't know why we can't, but we have been unable to find that level of staff. And we feel that, for the time being at least, outsourcing this particular section of the lab is the better route to pursue. It is budget neutral. There's a few $1,000s that it saves us, quite frankly. But we calculated our cost, finance did the analysis, and the bid that we received from ProPath was a little bit less than what we're currently spending. So I would request your consideration and approval of outsourcing anatomic pathology to ProPath.
Discussions for Bill regarding this matter?
Turnaround times, Delta.
They have 2 pickups a day. The benefit is now we have a 7-day-a-week service. Historically, we've had 5-day-a-week service, right? So now it's 24/7, and they're going to provide 2-day-a-week pickup, so we shouldn't have an issue with turnaround time. It provides a lot of quality reports that we haven't had before. It tracks the specimen paperless versus what we're doing now, so they're tremendous benefits in cost efficiencies.
Reverend Nixon, you had a question?
On the procurement, the diversity procurement side, on the diversity policy,
Yes, sir.
does the company say to us we're under the excluded category, or do we determine that they're under this excluded category? Do we automatically, and I may not be asked, should be asking that, I should be asking Nidia, I guess, but do we automatically check the block because we look and see what that company is? I guess I'm trying to get to, how do we get to determination of it's an excluded category?
Well, this is a professional agreement, but it's an amendment to a current relationship that we have with ProPath. ProPath provides all of the pathologists to this organization and has for a number of years. So this is an additional service request that we're tagging on to the current agreement.
Right,
Right?
okay, right. But
What we've done before, historically, when we brought the ProPath agreement to you, is attach that MWBE
Right.
collateral information.
okay, okay, right, and I understand that.
Okay.
But I think if you go back and research on ProPath, they actually comply with the district's MBE, WBE.
Okay.
Okay, and that's when I asked that question, because we, on the contract here, we checked that it's an excluded, but
Actually, do comply.
Yeah.
Maybe in compliance, I agree with you, Ralph.
But your point is, let's document the fact that they
We're
are in
compliant.
compliance.
yeah.
Because the total amount of what we contract in that area
Right.
works with us on the percentages.
Right.
Point well made, Ralph.
Very, very well
point.
made.
Any other again, Bill, thank you. We know this is an amendment to the existing. If there's any other discussions, we enter it now. If not, we entertain a motion.
So moved.
I've got a motion by Dr. Casey and a second by Reverend Emerson. All those in favor say aye. All right, Bill, thank you very much. Again, apologize for other.
No, my mistake.
Item number D.
So now moving to Morrison Dixon, our drug wholesaler, of which this is approximately a $200 million contract over 5 years. They did provide a steeper discount than any other bidder. It is a larger discount than what we're currently enjoying with Morrison Dixon. Many of the other features we retain. So I would ask your consideration, be happy to answer any questions that perhaps you have, and I know I have backup in the back of the room to answer the details that I don't have a grasp of, but we feel very confident that this relationship is one that we would recommend continue.
I would like to ask one question that came up in P&T yesterday. I mean, we go over the budget, and for in-hospital, we're pretty good about staying within the budget, and for outpatient, we're always way over budgeted. And I guess the question that was raised is, how can we fix that? Because it just seems like we have a budget, and then we never even come close to it. We're hundreds of thousands of dollars over every month. Mostly because there's more patients with needing more needs, and the price of medications going up, and it's just impossible to get a handle on. And the question was raised, is there some way we could adjust the budget?
Well, without knowing what happened yesterday in PT, my perspective is that we under-budgeted the cost of pharmaceuticals in fiscal year 17. I think I am pretty confident in saying that, and we've adjusted that budget for 18.
Okay.
So I anticipate we'll be closer, but actually pinning down the cost of pharmaceuticals, you know better than I, is a difficult task. Very difficult.
Yeah, I mean, every month we look where we can save,
Right.
and it's just a Herculean task to do so.
Well, it certainly is, and remaining with Morrison Dixon, I think, will give us a better opportunity to be more cost efficient in that area. DT?
We have a quick question.
Mr. T.
On this one, I guess the contract is pretty long, so I'm a little bit, I just need to understand a little bit more. Is that, are we paying the discount we getting?
Are we
is
what?
The pricing, and so these are the prepay that will give us the savings, or? Because I saw the
These are
pricing strategy.
as we acquire the drugs, then we would be billed from Morrison Dixon approximately a 7.28% discount from WAC.
Discount, And is this different than the Vision contract that we signed?
Is this
a few
what?
Is this different from the Vision contract that we signed a few months ago? How does that work? Because
With Morrison Dixon? Nicole, do you have the answer to that? I'm not aware of what.
Vision isn't drug-related. Pharmaceuticals don't go through Vision, I don't believe. Not-
With Vizient. Oh, that's what your question was,
right,
not
so it's
Morrison
different than,
No.
we don't buy drug from Vision,
No,
we just buy
no,
from
this is a separate agreement, wholesaler agreement.
Are these based on AWP pricing or WAC pricing? The wholesale? I'm just,
Nicole, I'm gonna have Nicole come up. Nicole Showquist
AWP versus the WAC.
And she has attempted to come up once or twice, so we're gonna bring Nicole up.
So the pricing in the Morris-Dixon agreement is actually a blended discount. So they actually gave a discount that's specific to the 340B purchase product, and then a discount based on WAC retail price.
so we do using WAC, not AWP?
Yeah, so if it's non-340B eligible, the discount's based on WAC.
Okay. And do we get certain rebates if we hit certain threshold based on?
So we don't get additional rebates from Morrison-Dixon. We have the reverse. If we don't meet a 50% 340B purchase threshold, we do have some penalties to the cost of goods discount.
Oh, I see. And is there, I don't see the take-back charges type thing. Is
So
there?
we get 100% credits within
Credits.
60 days of the purchase of the product.
Yeah, that was in there.
I'm good.
Good. Did you, okay, anything else? All right, sure, thank you.
Okay?
Any other questions for Bill in this regard? If not, we entertain a motion.
Motion.
Thanks.
BT on the motion. Ralph on the second. All those in favor say aye.
Aye.
Thank you very much. Bill, while you're there, I guess we're gonna move right into E.
Okay, the next two agreements are really interlocal agreements between Tarrant County and MHMR. We have brought these agreements to this committee for the last several years, every year that I've been here. We're the payer. This first agreement is between Tarrant County and MHMR. It's an interlocal agreement, and it is for $14,163,476, and every dollar of that is included in our fiscal year 18 budget.
As y'all know, I think GK actually came last year and presented these, if my memory's correct, Bill.
He might have.
Yeah.
The mental health.
Might have.
Again, this is something that's been in our budget for, I think, as
Correct.
long as I've been here. It's just something that the county, it overlaps into our budget, and it's obviously on here for our approval. So we would open for any discussion, but we need to take a separate vote. Correct me, Corey, we need to take a separate vote. So the first one I would do would be item number E. I would entertain, obviously, any discussion for Bill, but again, this is the Tarrant County that's been in our budget for years, so they provide these numbers. We have a motion by Reverend Emerson, a second by Dr. Weber. All those in favor say aye.
Aye.
Thank you very much. And Bill, while you're there, we'll go ahead and take number F.
The second
which-
amendment
yeah.
is likewise the first. This is with MHMR. MHMR does provide certain services to the county, of which we purchase a portion of those services in regard to addiction treatment and court liaison aftercare and things like that. Again, this is a very similar contract. I think it's the same amount of money that we asked for your approval last year, and it is included in the fiscal year 18 budget.
I have a motion for approval by Reverend Emerson, second by Dorothy. All those in favor say aye.
Aye.
Opposed, no. Thank you all very much.
Okay, thank you.
Bill, thank you very much. Item number G, I think Kathleen Slayman's going to come up here on item number G.
Good morning.
Good morning, Kathleen.
I'm here representing Jamie Ply, who could not be here today. And he is requesting approval in your consideration for a service agreement for radiology equipment that you had approved and we installed in the last 18 to 24 months. That includes 2 fluoro rooms, 3 CTs, and 1 MRI. We have been replacing those units over the last time period, and as they're coming off warranty, we're asking for service agreements for a 7-year plan. However, understand that not all the units are coming off warranty at the same time, so it will be prorated and paid as they come off the warranty and go into the service model.
Move approval.
Motion by Dorothy,
Second.
second by Reverend Emerson. All those in favor say aye. Aye. Sorry, Dr. Casey, I think you're, Kathleen, thank you very much.
Let the record show that Jamie Polite owes
Did
you a
it,
line.
yeah, he does. Item number H, we're going to not consider at this time. It'll be discussed further in close, which would take us to item number I. And good morning, Wayne.
Good morning,
All
sir.
yours, thank you.
Thank you. So item number I is an interlocal agreement between us and Fort Worth ISD. For as long as almost anyone can remember, Fort Worth ISD has provided educational services to our adolescents who are admitted to our inpatient psychiatric facility. There is some regulatory requirements about the number of hours in a day that the youth have to have access to education and receive educational services. And so Fort Worth ISD provides 2 homeschool teachers that are employed by them and a teacher's aide for the classroom activity that we have in Trinity Springs. And there is no cost associated with this service. They enroll the children out of their home district and into Fort Worth ISD, and then transfer them back to their home district as they're discharged. So that funding mechanism that supports the school districts through the normal process is in play with that process. So we don't pay for this service in any way.
So a good program with no cost to us.
Absolutely.
That's a good one. Any discussions for Wayne relative to this?
Move approval.
If not, I have a motion by Dorothy for approval. Second by Dr. Casey. All those in favor say aye.
Aye.
Thank you very much. Wayne, item number J.
Yes, sir. So item number J, I brought 3 agreements to this committee last month where we purchase inpatient psychiatric care from other hospitals when we find ourselves in an overflow situation. Historically, we have had 4 facilities. One of the facilities opted not to contract with us going forward. And so I tried to find another facility that might be agreeable to providing care to our patients. We're in that overflow situation. This one is a little further. As their name implies, it's Dallas Behavioral Health. Their intention, they have located a facility they intend to operate within Tarrant County in the near future. However, having access to the 4th hospital would ensure that we can resolve a crisis before it escalates when we are in a saturation point. As it happened this past weekend, we had 3 of the 4 hospitals that we currently contract with were at capacity, and so it makes me a little uncomfortable only having 3. We do not anticipate spending more as a result of having this. It will just distribute those funds differently among the hospitals that we use to provide that care.
Okay. Any additional questions for Wayne regarding this one? If not, I entertain a motion.
So moved.
I have a
Second.
motion by Dr. Casey, second by Mrs. DeBose. All those in favor say aye.
Aye.
Thank you very much.
Thanks,
Wayne,
sir.
thank you very much. Thank you for all you do. I think we have, items K, L, and M deal with, school base. And we have Dr. Karen Duncan. And good morning.
Good morning, how are you?
All right.
My
Is this
first
your
time
first
coming-
present?
Yes,
All
it
right, well, welcome.
is.
Thank you
So-
very much.
And I'm glad they're easy ones.
We won't be too rough on you, I promise you.
Can't say that before you start.
Yeah, it's when it's over with, Karen. So,
Well, it
anyway,
is-
welcome. So, all yours.
Thank you. So items K, L, and M, as you mentioned, are our interlocal agreements to continue operating our school-based clinics. K is our interlocal agreement between Tarrant County and Everman Independent School District. As you know, our school-based clinics are great services for the children that attend schools and also serve their families. Everman this year is slated to see over 3,600 visits, and so I come before you to request your consideration and approval to renew this agreement.
I've been told by council we need to approve these individually, so I'd entertain a motion on K. Dr. Casey on the motion. Reverend Emerson on the second. All those in favor say aye.
Aye.
Thank you very much.
L is the interlocal agreement between Tarrant County and Crowley Independent School District. This school-based clinic is,
Second.
Karen, they're being rough on you, so go along with this. Reverend Emerson just made the motion to approve this, and we have a second by Dr. Casey.
Okay.
So that will get us,
Part of that was because Crowley is a good
Yeah, yeah,
place.
no,
The
no,
other part
I-
is Pastor Emerson wants to beat Dr. Casey. So,
well, and I will,
He's
yeah,
faster than I am.
yeah. I will be quiet and let you go to item number M.
okay, so M is between Tarrant County and Fort Worth Independent School District. This includes the Eastern Hills School-Based Clinic, the Forest Oaks School-Based Clinic, Northside School-Based Clinic, Southside School-Based Clinic, and Western Hills School-Based Clinic. And these.
Second.
I have a
Very
motion.
much.
I have a motion by Reverend Emerson, second by Dr. Casey. All those in favor say aye. Aye.
Thank you very much.
Yes, Dr. Duncan?
Karen,
Karen.
They just couldn't let you do it.
Somewhere about using telemedicine in schools. Is it something that we could adopt or look at, or?
Yeah. So we are looking at all of our school-based clinics and how we're providing care. Telemedicine is one of the areas that we're looking at, especially with behavioral health with Wayne here, but and some of our specialty care too, which has been a little difficult for some of our children to access.
Excellent.
Karen, when Roy and I was at the conference in Colorado Springs, there were some board members, and we were talking about school-based clinics. So you might get some calls, because that was one of the topics that everyone at our table was talking about, and those that were sitting around us came. And so we passed out your name very freely.
Thank you very much.
Second.
Karen, thank you very much, and see, your presentation, everything's approved, and again, excellent presentation, thank you so very much.
Thank you.
I will say, I know many of you in this, on this board, and this committee, and also on the board have been through the school-based clinics, but if you haven't, I would certainly say, I know I've been in Crowley, I've been in Everman, I've been in Eastern Hills, I haven't been to all of them, but it's certainly something that, it's amazing to see what they do. Yes, Reverend.
Chairman, let it go from that, to commend Robert and staff and JPS, because that is, I'm discovering that is rarity.
Right.
Right?
Because it's a hospital association conference in DC, we were in a meeting, and I brought that up, and everybody wants to know about.
Yeah,
I totally agree.
good.
Thank you.
Excellent points both ways. Item number, I think NOPQ, one is going to deal with our home health care, so we'll start with item number N.
Thank you. This is just renewal for our home health agreements. We currently use 4 different companies. We're required by law to offer our patients a variety of different home health services companies, and then they have to pick the one that they choose to go to. So this is just renewal for that. We see over 1,200 patients every year need to go out of the hospital and have home health care services and be followed by the home health company and their primary care physicians. So the first company up is Rosa's First Quality Home Care. All of these companies have been providing quality care for us, and we've not had any issues with them, so that's why we're seeking to renew these at this point. So the first one on the agenda is for Rosa's First Quality Home Care.
Any discussion regarding these? If not, I'd entertain, Dorothy, do you have a question?
Approval. I have a question.
I have a motion for approval from Mr. Bowes, a second by Reverend Emerson. All those in favor say aye.
Aye.
All right, thank you very much. Wanda, number
The
O.
second is for Claris Home Care Service Agreement. It is the exact same.
Same thing.
Same thing.
I think the point was well made that you feel very comfortable with these that you're representing. We haven't had any issues, so I think that goes a long way for this committee. So if there's no additional discussion, I entertain a motion on 0. I have Dr. Casey on the motion. Reverend Emerson, a little slow on that one. Second, all those in favor say aye.
Aye.
Thank you very much. Number P.
The third one is for Health Masters Home Care Incorporated. The same.
I have a motion by Reverend Emerson.
Second.
Second by Dr. Casey. All those in favor say aye.
Aye.
And then honest number Q. Wanda.
And last will be for Amazing Grace Home Care, or Home Health, I'm sorry.
So moved.
I have a motion by Dr. Casey.
Second.
A second by Reverend Emerson. All those in favor say aye.
Aye.
Opposed, no. Thank you very much. I want to thank you for covering all those. While you're there, if you would, just go ahead and cover item number R. We appreciate that also.
This is for approval of purchase agreement between Howmedica Osteonics. And this last month, I presented the reprocessing of our X-Fix devices and buying those at a lower cost. This is also related to X-Fix devices, but there are some that we'll need to buy that are new that we'll have to buy at a lower cost, but they will be more than the reprocessed one. So we had to break it down into 2 separate contracts. We couldn't do them together. So this is just the second part of that contract. But it is a cost savings initiative that we're implementing in the operating room, which by renegotiating this contract will save us $240,000 annually, or $720,000 over 3 years.
Second.
Based on those savings, I heard a very quick motion by Reverend Emerson on the motion, a second by Dr. Casey. All those in favor say aye. Aye. Thank you all so very much. Item number S really needs no action. It was part of a contract previously approved by this committee and the board, so it's already been taken care of. So it would move us to item number T.
Okay. This is for the purchase agreement for Intuitive Surgical Robot for the XI console system. Our original robot was purchased probably around 10 years ago, so it is has met its life. It's considered now to be obsolete and is being sunsetted by the company this year. So we'll no longer be able to get parts for it. The technology at this point is so much more advanced. None of the surgeons want to use this piece of equipment anymore. And so there is a new system that is out that we are requesting to purchase, that we submitted in the capital budget this year for the new Da Vinci Xi robot. This will be used by urology, general surgery, and gynecological surgery. This will give us the ability to still have 2 robots, and because we have scheduling conflicts between the different services, it's really good. We really need to have 2 robots in order to provide the service that we need to have for our patients and our physicians. It also includes, there will be a service contract for this piece of equipment that will be coming at a later time. The first year will be covered in the contract, of this contract, and then after that, there will be a contract that will be required annually, but that will be covered through the biomed department. And we are able to trade our S system in for a $75,000 trade that will be applied to this purchase.
Good. In reference to item number T, I have a motion by Reverend Emerson for approval. I would ask Ralph if that also includes the comments. I'm advised by council that we need to include the comments. You're also approving it. It was an exception to the bid process. Yes. So I have a motion. Do I have a second? Second. I have a second by Dr. Weber. All those in favor say aye. Aye. Thank you very much. Yes, I'm sorry,
Do you know
Dr. Ziegler.
when it will be operational? Because I get asked constantly when the new one will be operational.
I can get that for you. I don't know
Okay.
right off the top of my head. They have a
very
pretty quick
soon.
turnaround.
Very soon.
As soon as we order
The
it,
other-
I think they'll start bringing them in.
One thing that the company actually makes more money on their instruments than they do on the actual device. And so that would be one thing I'd want to look at. We should look at and just make sure we get a fair deal on the instruments. Yeah.
We're always looking
Yeah.
at all this type of stuff.
We are still using the S device, but it really belongs in a museum. And it's, so this will be a welcome addition.
Robot museum.
Good.
Yeah.
Dan, appreciate your comments about the instruments too. Wanda will certainly address that. So, item number U, is that,
No, that's.
that is
That's
set?
not me.
Melinda.
Sorry about that. Melinda. Wanda, thank you very much.
Good morning.
Melinda, good morning.
I have 2 this morning. The first one is 3M. This is an annual renewal of the 3M contract. Just a reminder for you that this is the tool we use to code all of our medical records and use the clinical documentation improvement functionality to make sure that we've picked up everything we should pick up when we're coding and get accurately paid for all the activity that was associated on that account. We are trying to narrow down what we pay any of our vendors that is unnecessary. So notice we did remove some of this contract for about $10K, and that was a translation table from ICD-9 to ICD-10. You may remember we went to ICD-10 several years ago, and I think all of our coders now that Madura's team uses in HIM are very familiar with the ICD-10 code, so we did take that out of the contract, reducing the costs.
Any questions? And I would ask that the motion also would include the exception of the bid process. So I'd entertain a motion at this time. I have Dr. Casey on the motion, Reverend Emerson on the second. All those in favor say aye. Aye. Thank you very much.
The next one is, once again, the annual renewal for our contract with Elsevier. Elsevier is what we use to provide additional patient information to our patients on our after-visit summary. So you may be aware that once we discharge the patient, we always create a after-visit summary for them, letting them know that they were here, what happened, what their diagnosis was, and the purpose of this content is to give them additional information about their diagnosis so they can appropriately follow up their care.
Okay. Any other discussion at this time? If not, I'll entertain a motion.
So moved.
I have a motion by Dr. Casey, a second by DT. All those in favor say aye.
Aye.
Thank you very much. Item number W. David, good morning.
Good morning.
Did you get the impracticality on Elsevier?
Which
What? Thought you said it for both.
Which one?
I believe motion covers
The
the exception.
the motion on all will include the exception to the bid process.
On B as well?
That is correct. Thank you. David?
Very good. So this particular contract is a contract with an organization called Forsyth. This is a new company that we have not done business with in the past, but we're looking forward to a good relationship with them moving forward. They won the bid on this particular maintenance contract. This maintenance contract is for all of our storage area network, where we store every medical record, every piece of information about finances, about clinical information as well. So this is the maintenance agreement for that piece of hardware.
Any discussion here? If not, I have a motion by Mr. DT, second by Dorothy. All those in favor say aye.
Aye.
Thank you very much.
We actually have two. So we have two data centers, one in Richardson, Texas, and one in the basement here. And we replicate between those two data centers. It's actually both. It's actually the maintenance agreement for both. Yep. Good, great question.
Okay. David?
So the next one is for a purchase agreement with an organization called Insight. This is to purchase some additional Cisco hardware as well as the VMware software licenses to go with that hardware to be able to continue virtualizing a lot of the applications that we run here at JPS.
And this was a budgeted item.
This is a
also,
budget
correct?
item, yes, yes.
Any discussion for David on this?
Move
If not, I have a motion by Mr. Bose for a second by DT. All those in favor say aye.
Aye.
All right, thank you very, very much. David, thank you very much. Kathleen?
Good morning again. I have two contracts today, and the first one is a purchase agreement with Medtronic Services. Medtronic is a vendor who has responded to an RFP. We had actually 17 responses, and this is for disposables and implantable supplies in the cath, EP, and IR labs. It includes things such as vascular and cardiac stents, pacemakers, coils, and ablation catheters. Due to the fact that our volumes have been higher than what we had anticipated, we were actually able to get unit prices much better than what we had been paying in the past. This is budgeted, and it is something that we are asking for approval today.
So moved.
Second.
I have a motion by Mr. Petty, second by Dr. Casey. All those in favor say aye.
Aye.
Thank you very much. Kathleen, item number Z.
The next agreement is for GE Healthcare, and that's for a capital purchase of a replacement nuclear camera. It is a camera that is 14 years old and has limited part availability due to the age of the unit. So we're asking for approval today for this purchase.
Any additional discussion over this purchase? If not, I have a motion by Dr. Weber, second by Mrs. DeBose. All those in favor say aye.
Aye.
Thank you very much. Kathleen, thank you very much. You want to go ahead and mention anything on the legal that you need to provide?
Contracts less than 200,000.
Did you see those, Ralph, in the packet? Yeah. Super. Any other questions or anything else for legal? If not, we need to go to closed. Oh, sorry. Yes, certainly.
I'd love to ask if staff would consider, when running the contracts, that even if the company does qualify in the excluded category, but if they also know that they needed the MBE, that we would check that block. Because there were several that were in the excluded, I just didn't say anything, that I know they need to have like a school district. And the reason I say that is because when we do, and I think we'll get that from Dorothy's committee today, when we talk about we're below the 25% spent, but if you go back and include those, then we will
Yes, sir.
be reaching the 25% spent.
Yes, sir.
Good point.
That's a good point.
Good
We
point,
appreciate
Ralph.
that.
More accurately reflect really what we're contracting, that we are complying with what the policies are. Very, very good point. Then, there being no additional discussion, I know we have another committee scheduled. We're going to go to close. Let's take about a 5-minute break if we can, and we'll come right back into close. Does that fit with you?
Yeah, just so y'all know, we only have one item
Yes.
closed.
It
And
shouldn't take too long.
not be long.
I think, Dorothy, we can stay on,
Prepare for your
we
12
can
o'clock.
stay on schedule for,
Okay.
for yours, so, anyway, thank you. That's a the open session at 12 o'clock, and we will reconsider and look at item number H on the agenda. And Wayne?
Yes, sir. So this item is to request approval for you to allocate $4.5 million in funds to address the environmental safety concerns for behavioral health patients. Those funds are available and have been set aside from the 2017 capital budget.
Okay. Are there any? I have a motion by Dr. Casey for approval of this. I have a second by Reverend Emerson on this issue. Is there any? If not, I'll call for a vote. All those in favor, say aye. Aye. Opposed, no. Wayne, thank you very much. Thank you very much. That being all the business per the agenda, if there's nothing else to come before this board, we stand adjourned. Thank you.
You ready to start?